just immersed in it. He said, "You would not believe how much work I have to do to just get a decent grand rounds together."
Who's this?
As a friend of mine.
Oh.
And it's kind of like this.
No, this thing just comes out of your ears.
Yeah.
Right.
Yeah.
You can't help it.
You can't help it. For Christ's sake, they had the Home Secretary of England here last night. That just is ridiculous in a way.
Hey, Wayne.
Yeah, I know you can ask one.
Thanks, brother.
I'm talking to people from my board. Have to go to a really good school. You know what though? It's not the education that they need. It will help them later in life. Being in an environment like this, having coffee right, with the princess kid from Saudi Arabia, that's going to help you. You know?
No, it's that network, yeah.
Yeah.
That is very true.
And it is huge. They did that when Stan first came up here last year in July. They spent 2 weeks doing just that with the whole class, the whole Kennedy School class. I mean, they were like, that's all they were doing was learning everything there was to know about each other.
Wow.
And it was, you know, putting them in
that's a
situations
very-
where they had to do.
It's a very B school approach. I mean, that's the way that.
But it was great, and he has, you know, and the contacts he's made with them.
And those people help.
Oh, we had Eddie Cooley when I was a resident as one of our visiting professors. One of the guys asked me, I mean, obviously you're very talented, et cetera, and you were there first for a lot of things. What made you so successful? Was all through Hopkins resident. Always made sure as we moved on in their careers afterwards that they kept everybody together. One got into a society, they got the rest of it. One gave a talk and they made sure the rest of it. You know, it's just that constant feedbacking.
Doesn't he have the wildest fingers? Yeah. And it's just amazing just watching those things.
Especially after he did about 7 bourbon.
I didn't see that part.
He was very impressive. Oh, man.
Yeah, they all that era they could all drink.
Oh.
What was the guy from Minnesota? Lily Hyde.
Oh, yeah.
I had to sit and dinner with him. This guy, little guy.
Yeah. All bent over.
I was, yeah, when you were running, I was.
I'm thinking,
Completely lucid, yeah.
and his speech pattern never changed. After a while, I'm thinking to myself, oh man, I gotta go to bed just looking at him drinking.
You started slurring your speech.
Yeah, I mean, I thought, geez.
It's good to start at read the book King of Hearts.
Yeah.
It's a biography. It's really actually a pretty good read.
Yeah,
Story
it
of
is.
Will and I.
He had a radical nectomy with his brother-in-law for a benign disease.
Yeah, who did it to him? Wasn't it?
Brother-in-law.
Brother-in-law, yeah.
It's his brother-in-law.
Yeah, but he hated him for it.
Almost
Well, then he opened it. He split his chest too, didn't he? Son of a bitch, how can you? But I mean, it's, Langenstein was his brother. It was Langenstein that did it to him, wasn't it? Owen?
I don't know. He just
Yeah.
really. He only referred to him as his brother.
Owen Langenstein.
And computers, so I can check it. I kind of wish not to look at it.
JFK スリットを踊りのすぐ後ろのバーベキュー
Scalp laceration on a little girl using a little hair suture. And then, well, you know how things get
Sorry?
elaborated on over time. It wasn't quite like that. It's the story of my father. I was playing golf and of course, we had a pretty good range to go. My partner and I were up pretty well. And that was fun. We're waiting to tee off on the back. Dr. Cool,
do this. I'm
Right,
going to do this
right.
on Monday.
But are you
It'll
ready
work
to
great
lose
for
your
this
job
order.
over it?
Yeah, no, I'm not. And I
He
work for
told me it was
myself.
his secretary, which makes it even too easy.
The last time he was terrible.
What is he doing now?
Nothing.
Larry says he's in between jobs.
Yeah, nothing. He's got, so like this fiscal year he's covered, but you know, September he's got to find something.
Well, you know what? That amazes me because I'm in a community hospital. I have another group that does hearts, and we are like mortal enemies.
Yeah, sure.
See, you've got to learn to cooperate. We had the same situation in Rochester, and they were fighting like cats and dogs, and they finally said, look, let's cooperate. Life gets better. We don't have to fight for all the resources. It's just one of those.
Stupid, but they.
Yeah, but you know the other group like just says stuff about us, which is just they're like underhand.
Yeah.
So when you have if it's a fair fight, you can just stop and say, okay, listen, the only two people that didn't beat up is you and me.
Right.
So let's beat up somebody else. This guy, he is.
But I mean, are the people that he's saying it to, does he know that you guys are enemies? That he's not your
Oh.
friend? And
Yeah.
What are you doing? How long do you get to stay?
I mean, people know. There's no love lost.
bad.
I mean, that conflict alone prevents us from doing 95% of what we're talking about.
Yeah, sure.
And then it was even better that as bad as our conflict buddies, cardiology groups, the major cardiology,
They're even worse.
they're even worse.
Yeah, they are.
Yeah, we had that.
'Cause they're all interrelated somehow. You know, at one point somebody's partner.
You got to keep the scorecard. Who you with now? What number do I call you that?
Which is funny because like there's 4 major orthopedic groups there. Don't get along. In fact, I can't even tell who's in whose group. I gotta like think. Oh, you know why it's right.
Yeah, but the ortho. Well, there must be enough cases then.
For the ortho guys, yeah.
That's the reason.
I gotta find me another job. Yeah, but you have to.
Yeah, but you come with time.
You come here and then all of a sudden you just get a job. How does it work? Academia doesn't reimburse me. Hustle and line.
Get a whole grain donut.
Good evening. I'm Miles Shore, and I'm a professor at Harvard Medical School and also a visiting scholar at the Wiener Center for Social Policy here at the Kennedy School of Government. And it's my happy opportunity to welcome all of you to this program. It's entitled, Is Medical Malpractice Damaging Healthcare? That title reflects in some way that this is a contentious issue. It's not a simple issue, one about which various groups in our country have very strong feelings. It's also an issue that has relevance much more broadly than in this country, because as health systems around the world change and evolve, the question of, particularly as they take on in some countries a more private character, the question of malpractice / compensation for people who have been injured becomes an international issue, not one that's solely limited to this country. The protagonists in this issue involve a great many groups and people in our country. Patients, attorneys, both those who represent patients and those who represent healthcare providers. Insurance companies are clearly much involved with this issue, as well as, of course, practitioners and healthcare institutions. At bottom, the general public is concerned about this issue because of the potential effects on the provision of health care, the cost of health care, and the fairness with which health care is delivered and administered. We're very fortunate that this evening we have a group of people, a panel, of people who represent the various constituents around this issue. Not all of them, I will hasten to emphasize, but enough of them that I think will have a representative set of views about what the issue is, what the issues are, and also hopefully some solutions based on a number of facts that not everybody knows about. Immediately on my left is Mr. Ed Dower, who is Dean Emeritus of the University of Denver Law School, and he continues as a professor of law at that law school. His field in the law is mediation and arbitration. He is co-founder and first president of the National Center for Preventive Law. What preventive law is, maybe we'll hear about. And in the past, he continues to be a visiting scholar at the Harvard School of Public Health, where in the past he earned a Master of Public Health degree. On his left is Michelle Mello. She's an assistant professor of health policy and law at the Harvard School of Public Health. Her undergraduate work was at Stanford. She was a Marshall Scholar and got an MPhil at Oxford. She has a PhD in health policy and administration from the University of North Carolina at Chapel Hill and a JD from Yale. She studies healthcare law and especially the tort liability system. To her left is Dr. Donald Palmisano, president of the American Medical Association, a general and vascular surgeon from New Orleans. His MD is from Tulane, and in the course of his quest through healthcare, he earned a JD from Loyola University School of Law. In addition, he has family connections because his wife is also a healthcare lawyer. To his left is David Schrager, a graduate of the University of Pennsylvania, both its college and its law school. He's a specialist in civil litigation, particularly complex and challenging cases of civil litigation. He's a past president of the National Association of Trial Lawyers of America, and earlier was president of the Pennsylvania Trial Lawyers Association. He's a member of the Board of Overseers of the Rand Corporation Institute for Civil Justice and the National Board of Trial Advocacy. I hope you will recognize in these introductions that I am on the platform with people who are all lawyers. Ed Dower asked me how I felt about that, and I said I felt very reassured because I never go anywhere without knowing where my lawyer is, and here I feel I have 4 people who can help me if I get in trouble. Having said that, I'd like to ask these folks one by one, perhaps starting at the other end with David Schrager. Is there a malpractice crisis? Is this a problem, or are we just blowing something up in order to have an interesting discussion?
Right. I think there's a problem. The question is, what's the source of the problem? What's the solution for the problem? But that there is a perception and in part the reality of a problem is not to be doubted. I think the important and for me the decisive question is to see what the problem is, its dimensions, and how we can deal with it. What are the alternatives that are not more perverse than what we can agree is the problem? Understanding again that the focus should be on healthcare consumers. They're really the people who are ultimately involved, and as our population gets older, as we become more healthcare dependent, I think we have to deal with this in a constructive way, not to destroy rights, but to keep the system within bounds and to see how we can better serve our citizens who need to deal with healthcare providers.
Mm-hmm. Dr. Palmisano, I wonder if you agree with that or how you see the problem.
Well, there is a problem. We agree with that. We believe the medical liability system is broken. We have 19 states in crisis, 140 million people live in those 19 states, half our nation's population. A crisis is failure to have access to care in your hour of need. It's a pregnant woman who can't find a doctor. When she goes into labor, she delivers her baby in a car on the side of the road in Arizona. That's a nurse who passes up Owen Hospital. It's a 9-year-old boy knocked unconscious. There's no neurosurgeon. Has to be air-evac to another place. It's a woman whose husband gets brain damage as a result of an auto accident. It could have been fixed, but there was no longer a neurosurgeon. The last neurosurgeon had left town. And we have doctors retiring early, limiting their practice, doctors who are moving to other states. In Pennsylvania, we have 1,400 doctors that have either left the state or restricted their practice, such as giving up obstetrics. And we find this as I travel the country, it's just getting worse. And as Aldous Huxley said, facts don't cease to exist because they're ignored. So what the AMA is recommending is that we all look at this and we base decisions on the facts and not on rhetoric. We put together a document we have at the AMA website, about 29 pages, and it goes through the common arguments pro and con, and we believe we have good references, including a reference here from Harvard that points out there's no reliability in this system, that the awards that are paid are not related to negligence, they're related to disability. So we have a system at present that decreases access to care, a system that decreases quality, increases the cost of medical care. There is defensive medicine as a result of this, and it's become a toxic environment. So we all need to work together, and we encourage legislators and folks in Congress to look at the facts. And we have that document, Medical Liability Reform Now, at the AMA website. You could look at that at your leisure.
In public issues, there is always an interplay between anecdotes, which are very important, and a set of facts that sometimes cast a slightly different light on things. And of course, what academics do is pull those facts together. From the point of view of Professor
Mello.
Yeah, Mello. Sorry. Professor Mello, from your point of view, how do the facts look? Is there a problem from your point of view as an academic?
Well, as an academic, my first impulse is always to decompose the question, so let me do that briefly. I think if the question is there a professional problem for doctors, the answer is clearly yes. That when doctors and hospitals tell you that they are struggling to maintain services under these conditions, they are not making this up or trying to simply garner attention to their own situation. They're highlighting a true and profound economic problem that they're facing. The question that I'm interested in as a public health student is this also a public health problem? Is it a problem for patients? And there the data are a little bit less unequivocal. So there, as you mentioned, are a great deal of anecdotal evidence to the effect that access to care is being affected. I think when you begin to look at the harder numbers, which are really only now beginning to come in, it's a little bit less clear. But in my opinion, there are some demonstrable effects on patient access to care as well as the quality of care. So my own conclusion is that yes, this is also a public health problem. The final dimension is, what will a patient say when you ask a patient, what's the malpractice crisis, what's going on. The patient is less likely to tell you about a crisis of malpractice litigation than about a crisis of malpractice. We now have an American public that is aware that between 40,000 and 98,000 people a year die as a result of medical errors. So from the public's perspective, the problem that we have to deal with is not only how do we solve these insurance costs that doctors and hospitals are grappling with, but how do we make healthcare safer? And can the system that we have now for medical liability achieve that goal?
Mm-hmm. So you're pointing out that there's been an evolution in thinking about this problem. That is, particularly the data on medical error give a very different kind of dimension to the issue of who should be compensated and in what way. Is that fair to say?
Well, I think what distinguishes this crisis from previous crises, and we've had two others in the last 30 years, is the recognition that there are sort of two faces to the problem. We are seeing a crisis of liability costs, but with the data that are now in the public domain about medical errors, there's also the recognition that there is in fact a huge reservoir of uncompensated injured patients whose needs also need to be addressed in some way.
Mm-hmm. Dean Dower, do you want to pick that up in commenting on the question whether there's a problem and what it's about?
I don't disagree with anything that's been said. I think it's clear that there are the kinds of distortions, both that Dr. Palmisano mentioned in physicians being unable to practice, particularly in places like in my state where we have docs in rural areas who simply can't afford to go there. But I'd like to offer a bit of context about this. The attention that's being focused on medical malpractice today, to some extent, is attributable to a spike in the cost of medical malpractice insurance for physicians. And to say it's a spike may understate it. For some people, it's been nearly catastrophic in terms of their ability to afford it and to conduct their careers. The thing to note about that, however, is that this isn't the first time we've experienced such a spike. As Michelle alluded to, these used to occur about once every 11 years. It's no accident that almost all of the tort reform done in the United States in this area was done in 1974-5, and again in 1985-86. And in 1986, many of us who were involved in it predicted we'd be back here again in about the year 1999. Economic conditions have pushed it out maybe this far. And so we're here partly because of questions about the insurance market, and the debate there is what drives that? Is it economic factors? Is it growth in the tort system? Is it a system that's run amok? My point, and the reason I give this context, is that there's something very, very different about this crisis. And that is that we now know a great deal more about both what's lacking and what's needed in the area of patient safety than we ever did at any of the other times when attention was riveted on this, whether in the middle 70s or the middle 1980s, largely because of work that's been done here at Harvard, plus other kinds of work. And this, to me, is an opportunity to do something that might be very, very useful with respect to patient safety and the quality of health care. My concern is that legislatures, or at least some legislatures, are being talked to in terms of changing the tort system to make insurance affordable so medicine can be practiced. And that is eclipsing a concern that I have, which is, can we change the tort system so that it conduces to higher quality care? I think that voice is one that needs to be heard, and it may be underneath some of the other voices that are being heard.
We've talked so far, we've emphasized the compensation of people who've been injured. But there's another side to this argument, which is that this system conduces to better practice, that it alerts doctors, disciplines them in a sense to be more careful. Mr. Schrager, is that something you're...
I think it's in part true. There's a lot of debate in the literature about whether the system has that effect or doesn't, but in looking back at my own set of data, which I think takes me to the screening of about 4,000 or 5,000 cases over a lot of years, very few of which, incidentally, turn out to be meritorious cases, but invite the question as to what was the negative medical experience that brought people to the lawyer's office. and litigating some of those cases, you learn certain things that do show a salutary impact, I think. For example, there is a large number of cases in which physicians are going beyond the ken of their particular expertise. A failure to make referrals to those men and women who are doing it for a living, let's put it that way. And I think in the present atmosphere, what I've seen, and I talk to a lot of physicians as well as to an awful lot of patients, I think there's a reluctance to take on high-risk work which is salutary, which is a good thing. If someone told me there was no neurosurgeon in 3 counties, but that there was a good teaching hospital in a 4th county, I wouldn't worry so much, unless it was, of course, somebody gave me an inflammatory anecdote about an emergent situation and somebody died because couldn't get a neurosurgeon. I've heard that type of case talked about. I haven't really seen that case face to face, but I'll defer to those who know the anecdotes. But the point is that there is a salutary effect of the system, referring to teaching hospitals in certain cases. I think it's, if you had a heart problem, you might prefer to go to the Cleveland Clinic than to Podunk General Hospital. I don't say that disparagingly, because frontline medical care is essential to the health of the community. But when you get into the high-risk work, where the mega verdicts sometimes come, and where we see the big headlines, I think it's pertinent. And when I hear, just to conclude on the point, when I hear physician colleagues of mine who will say, hey, listen, I tell these guys, if you don't chart it, if you don't get the medication right, some of these contingent fee lawyers, they're going to get hold of you. I find that the system is salutary. It's kind of I don't know whether that's a criticism of the system or a badge of honor, that the portent of potential legal liability does make a physician who otherwise, the rare physician who otherwise might not be sensitive to the standard of care, to think twice.
Mm-hmm. Dr. Palmisano, I bet you have some thoughts about that.
I do. First off, I would invite David to look at the testimony that AMA gave and others gave before the Judiciary Committee of the House of Representatives as far as these emergency cases that he has not met these people face to face. Look at Leanne Dice's testimony about a husband who has that brain damage. That's a real person. It's easy to check her out, and all of the other folks that we've presented. It's a real problem that's happening. As far as it helping with safety, helping medicine by having litigation, we've found no evidence of that. We haven't found anybody who's brought up any documentation that it does that. In fact, it does just the opposite. The American Medical Association, and by the way, we take a different opinion with the figures that's banded about the 44,000 and 98,000 deaths published in the Institute of Medicine report. That wasn't a study that they did. Those were old studies that were taken from New York hospitals, Colorado and Utah hospitals, and small number of patients extrapolated to the rest of the population. Some of the original people involved in that have criticized the use of it in that way. We say one error that harms a patient is one error too many, and that's why we founded the National Patient Safety Foundation in 1996, fully operational in 1997, and the AMA has donated over $6.5 million to that organization, separate organization, not-for-profit, one mission only, to measurably improve patient safety. Our colleagues in the trial bar, we've invited them to match our donations repeatedly. We had the president of ATLA come to the House of Delegates, give a presentation. We've invited them in TV programs to yet, and I checked with them today, no money has been given yet. So we look forward to matching our donations on that particular issue. There is a way to make medicine safer, and we want to do that, and that is to use what allows me to fall asleep on commercial aviation as I'm flying across the country every day. Tomorrow I'll leave for California, and I'm crisscrossing the country, and I fall asleep immediately. As soon as I get on the plane, put on my little earmuffs and patch my eyes up and just fall asleep with my little neck pillow. And the reason is because there's something called the Aviation Safety Reporting System. It has made commercial aviation extremely safe. It's voluntary confidential reporting by pilots by flight attendants, by mechanics, reviewed by experts, feedback immediately to those involved, and send the information out in a de-identified fashion. It doesn't take away the rights of any patient. You still have the ability to sue, the ability to use all the discovery mechanisms. That system is in 663 in the House of Representatives. It passed with only 6 dissenting votes. In the Senate, it went through the Health Committee, Companion Bill 720. It went through there with no dissenting votes out of that committee. It needs to be pushed over the goal line. There should be nobody in America against that bill. That enhances patient safety. The current system just drives safety underground.
You know, I would prefer to get my information on with respect to standards of medicine and patient safety from the Institute of Medicine rather than from the American Medical Association, and from other groups who have an academic, not a political interest in the subject matter of safety in the practice of medicine. The importance of this it should be evident, and that is the best way to knock down claims is to be sure that we do our part in support of the practice of medicine in accordance with the best state of the art. And I'm delighted to see that the AMA is now actively involved in that business, especially since, as the Dean reminded us, insurance rates have gone up substantially. I think there are several pieces to this pie, and there can be a lot of shots sent against trial lawyers. We've heard that before, and we're never going to be popular except with our clients. But the point is that safety in the practice of medicine to obviate and lower the frequency of claims would be one of the most salutary things we could do. Do you agree with that?
Well, we certainly agree safety, but on any given day, there's 125,000 suits pending against physicians. 70% of those suits will be closed with no payment. The ones that go to trial, the physicians will win 80% of the time. I'm a surgeon. I make the diagnosis of appendicitis. I get informed consent to operate on the patient. Imagine, I get instant peer review from the pathologist. Imagine if 70% of the time I had a normal appendix reported back. The tissue committee looked at that. They wouldn't let me operate. We need a little peer review for the attorneys. That's the first thing we need to do, to make sure. We volunteer to serve on these committees. How many times do you go to your colleagues and say, let me look at all your cases? Maybe what we need instead of contingency fees is legal care. Just like we have Medicare and Medicaid, and we pay the attorneys by the hour, we have fraud squads that are set up in government, and they come by and they look and see whether this is legally necessary, like medical necessity, and then they come in and extrapolate from a few cases and say, oh, sir, you owe us $500,000, you owe us $1 million, and then you'll have your due process after you pay that money, and then you can fight and hire a lawyer. That's maybe what we need. This is a system where patients who are truly injured, and if they win a case, although Troy Brennan has said there's no correlation with negligence, but if they win a case, let's say they get $1 million future medicals, who takes anywhere from 33 1/3 to half of that? Who takes care of the patient? The attorney takes $500,000 of the medical. Who takes care of the patient the last half of their lives? I don't see the trial lawyers setting up a fund to pay for those patients. We all take care of those patients through the public system. We can do better than this in America. The best medical care the world has ever seen, and it's being destroyed this very moment by a system that's out of control.
I would hate to take the juice out of such a lively discussion, but we have an expert on conflict resolution sitting next to me. And he's been taking a deep breath. So, Ed?
Actually, hearing the audience's reaction to Dr. Palmisano's comments, I feel much reassured that I'm next to my doctor. I think the question of whether the liability system actually changes physicians' behavior for the better or the worse is a question of increments. I don't think anybody is realistically talking about junking the whole thing. The question is on the margin. That is, if we do things like put in caps, if we do things like change it this way or that way, are we likely to change it a great deal? My own view, although part of this is based on data about which Michelle is much more astute than I, and part is based on anecdotes and my own observations, is that we probably need a liability system combined with a good competency-based regulatory system. And if we got rid of either one of them entirely, we'd be in deeper trouble. I do think, however, and I'm taking a middle view here, not because I'm a peacemaker, but I do think, however, that there are some flaws in the liability system about which Dr. Palmisano is quite right. And this goes back to what I was saying about what we've learned since the last insurance crisis, and that is something about patient safety. Just to give one example, one of the things we know is, and I'm no expert on patient safety, this I get from reading what everybody can read, one of the things we know is that most errors, I can't give you a percentage, but most errors that result in injury are the consequences of system failures rather than incompetence on the part of a single identifiable person. The difficulty with the tort system is that it operates counter to that insight. It looks for the person who was negligent in that case on that day. And as a result, it's out of whack in ways with what we know about the requisites of patient safety, in ways that actually probably have, though we've not studied this well enough to be certain, probably have some real effects. One other is that there is, however much we argue about its accuracy, there are random events. And in fact, the data do show, and again, I'm going to defer to Michelle on this, that whether a physician was negligent or not is maybe one variable that predicts whether they'll be sued, but other variables are the nature of the outcome. People who were seriously injured seem to be more likely to make claims. Now, under those circumstances, I'll share with you a quip that somebody, I wish I had thought of this, so I don't know who did, but I'll tell you it's not mine. Somebody once said, if you want to train people not to go through red lights, you should probably only give them tickets when they go through red lights. You shouldn't give them tickets when they go through red lights and green lights, and you shouldn't not give them tickets whether they go through red lights or not. And so to the extent that the penalty, which many physicians see it as, of a claim being brought against them, is random with respect to what they perceive as the quality of their care, it seems that we have a system that isn't using motivations as well as it might. And to that extent, can we make it a little better while still maintaining what I believe is true, and that is the impetus or the incentive to take care that comes from the possibility of paying some sort of penalty if one doesn't take care.
Michelle, there have been some questions about facts thrown in your direction. Would you like to comment on some facts that might help us to think about this?
Sure. I think deterrence is another one of those areas where you have a bit of a separation between anecdote and data. We have very compelling anecdotes of cases of incredible deterrence, and probably the best known one to those of us who live in the Boston area is the Dana-Farber Cancer Center and the Betsy Lehman case. That case, which was very tragic, very serious, and very well publicized, has prompted organizational overhaul on patient safety, and it's a good example of what a lawsuit can achieve. Now, having said that, when you look at the data about how hospitals, much less doctors, react to being sued, it's very difficult to find any correlation between perceived malpractice risk or past claims experience or even malpractice premiums and their rates of errors, which is pretty discouraging. Now, what Ed highlighted is that perhaps this mistargeting of liability at the level of the individual physician is partly to blame. And there are a couple of reasons why we may suspect that that's the case. One is the reason that you highlighted, which is the doctors may not have control over a great deal of the errors that happen. Now, we don't have really good data on that. In my judgment, the statement that most errors occur due to systems failures and not individual negligence is an informed hypothesis. It's one that we're testing now, but it's not one about which we have good data. But if we think that's true, then the answer is perhaps to shift liability. Now note that that doesn't necessarily mean abandoning the tort system. What it can mean is simply adopting greater enterprise liability and relocating negligence-based tort liability from the doctor to the hospital or the HMO or whatever we think the relevant enterprise is. But the other thing that may be going on here is simply that doctors and hospitals, although they both have insurance, suffer the economic consequences of lawsuits differently. Doctors, aside from being rated by their specialty, are not experience rated in their insurance, which means that they suffer some degree of insulation when they are sued and when they are recovered against. Now, there are many other devastating impacts of being sued, as I'm sure Dr. Palmisano will tell us. But the direct economic impacts of making a mistake aren't always felt at the level of the individual doctor. He may be dropped by his insurer, however, in this environment, which is an important factor. At the level of the hospital, though, there's a much greater opportunity to do experience rating and to make these economic incentives work as they're supposed to. So the conclusion I draw then is that there's greater opportunity to improve patient safety by somehow focusing responsibility, whether that's tort liability or some other means of making organizations accountable, at the level of the enterprise and not the doctor.
Can I add one thing?
David, I think you had.
Yeah, I would say, and Michelle introduces an important point. I think she would recognize that there are some who feel, on the flip side of that, that the best way to focus responsibility is on the part of the individual who himself or herself was actually at fault. Under the system we have today, which I think requires attention, all of these settlements, for example, recoveries, even for the smallest type of injury, even in arguable or problematic, I ought to say more properly, scenarios of alleged physician error have to be reported to HCFA. And physicians will often take the position they have nothing to lose, or more frequently, the reporting will be a charade. A hospital will report, it may report in the name of a resident. A staff physician, himself or herself, may not wish to be listed or perceiving of that to be a bad mark if, for example, he or she were to seek hospital privileges elsewhere. I think also when you have vicarious liability imposed on an institution, I'm laying aside issue where there is clear systems error, or where there is a policy deficit that for which a hospital fairly should be criticized. You have a real question as to whether you're not vanilla coding it. So the lawyer sues the hospital, and the hospital's liability is asserted on a vicarious basis for all of its so-called agents, servants, or employees, as we as attorneys would understand that. And there is some real question as to whether that's a good thing.
Mm-hmm. I'd like to move back for a minute to the compensation issue, because I think that I'd be interested in Ed or Michelle talking about the kind of the flow, the numbers in the compensation issue. How many people are injured? How many cases come to litigation? How many are compensated at that level? I think that's a backdrop that's very important to have on the table for all of us. Can you review that?
Sure. So these numbers come from two Harvard studies, one in New York in the mid-'80s and one in Utah and Colorado in the early '90s. And despite some pretty big differences between those two kinds of states, the numbers were pretty similar. They looked only at hospitalizations, and they found that in about 4% of hospitalizations, we see what we call an adverse event, an injury that is attributable, in the reviewer's judgment, to medical management. In about 1% of cases, we see an injury that's attributable to negligence. Now, when we look at the universe of malpractice claims, the finding is generally that 1 out of every 7 or 8 claims would actually involve a negligent injury. And when you take those two circles and put them together in a Venn diagram and ask the question, of those who are injured by negligence, who sues? The number is between 2 and 3%. Now, let me conclude by saying that there should be some confidence intervals placed around these numbers. This study has had methodological challenges like all studies, and the fact of the matter is, nobody is very good at evaluating what negligence is. Juries disagree about what negligence is, and in this study, some of the physician reviewers disagreed about what negligence was. So we ought to take those figures with a grain of salt, but even if they're off by half, I think they still paint a picture of a system that doesn't do a very good job of channeling compensation to people who deserve it according to the standards set up by that system.
And Ed, you've sometimes, I've heard you talk about the number of, out of the people who sue, how many actually come to trial and receive compensation? That's a different cut on it, is it not?
The number of trials that occur is almost trivially small. Almost all of the cases where there were claims made are resolved one way or another, maybe by settlement. And so we know less about this than we like to know from the official numbers. I would like, if I may, Miles, to continue, maybe extend Michelle's remarks
Sure.
In another way. The troublesome part of this for me comes precisely from the linkage between the two things we are now talking about. Compensation of injured people on the one hand, and the identification and, where appropriate, correction of a physician or provider or institution that may have made an error on the other hand. The interesting thing about the tort system for me is that it links these two together, and I think the linkage between those two is a source of a lot of trouble. To express that in what may be an oversimplified trope, it's nonetheless the case that in the tort system, before an injured patient can be compensated, they must prove that some identifiable physician was wrong. That is, for me to be right, you have to be wrong. There is no recovery unless I establish that this doctor operated below the standard of care, which is a community-based standard of care. That creates a process which is inherently polarizing, which creates inherently defensiveness. One of the things we know about defensiveness, I learned this in the 3rd grade, is you don't learn a lot if you're really defensive. And that polarization itself, it seems to me, creates some of the problems. It seems, not only that, but to use the tort system as a way of identifying and correcting physicians who may be operating below the standard of care is enormously random. Imagine, for example, 2 drunk anesthesiologists. They both come in and they engage in some surgery, and they both had a couple of drinks before they arrived. They're both engaging in activity which is immensely dangerous. Let's suppose that in one case there's an injury, and in another case there isn't, by the luck of the draw. The tort system fines and punishes only the one whose behavior caused an injury and leaves out the other person whose competence was just as low. And so on the one hand, we have over-inclusiveness and under-inclusiveness, but those are just a couple of examples about why, in looking at this problem and critiquing the tort system, my own critique focuses on what is it doing wrong, or what isn't it doing right from the point of view of real quality improvement. And I think that linkage between compensation and deterrence is the cause of a lot of its troubles.
David, comments on that?
Well, I think those comments by Ed, I think they're correct so far as they go, and it takes us back, though, to the importance and the salutary effect and the claims reduction effect of standards of practice that are well executed by those in supervisory positions in our healthcare institutions. I mean, this is one piece of it. Some are compensated, some not, because, and that's very troublesome, as are the studies of the mid-'80s, very troublesome. And it's a challenge to the men and women in the legal profession. It's a fair criticism in my judgment, because what you have are data that suggest that most eligible people who could participate arguably in the tort system and obtain compensation from the tort system don't use it. They're not using it, and the question is why? I think that number may be coming down. And the reason I think it's coming down, frankly, is a word that's not used. I don't hear it used curiously. It's called advertising. I think it's a very important piece in this. I think, and I'm not saying that pejoratively. I'm old enough that, as they say, thank God I don't need to advertise. So I'm not saying that pejoratively, and I'm not disparaging the Supreme Court of the United States' right to recognize something called commercial speech. But what's happening is patients, prospective plaintiffs in litigation, are becoming more sensitive and aware to their potential rights. That much is good, but then they have a level of expectation. And they start calling, and we get these calls, many of them. And the lawyers who are referring us cases, ours is almost solely a referral practice, they are the advertising lawyers. Now that's the fact. So there's been an increase 5 or 10-fold in the contacts that are being made of the lawyers by people who suppose rightly or wrongly they have a case. Out of that huge group population of people who think they might have a case, there is a very small number of real cases, although you might have a mix of talent in terms of the lawyers who handle the cases, because you don't have to have any certification to advertise the front cover of the phone directory. That's a real issue that deserves to be talked about out loud.
Mm-hmm. What's the answer to that?
I think the answer is that the bar must do much better in terms of continuing legal education and standards. Now, the contingent fee tends, curiously, from the point of view of many physicians, I'm sure, to have a very salutary effect. Because the one thing a contingent fee lawyer doesn't want to do is to take a case that will realize no fee, especially when you properly handle a medical negligence claim. If the lawyer knows what he or she is doing and is sensitive to their responsibilities, you could be spending $30,000, $40,000, $50,000. And most of the cases should be turned down flat. So the question is, what are we doing in the legal profession, even as we urge that there should be more concern in the medical community with respect to safety in medicine, that ought to be a piece of it. That'll be a piece of the reform, as it were. What can we do at the legal end? And we do better than we give speeches. If anybody wants to read my very conservative CLE outlines, you'd probably be in general agreement. But, and a lot of other attorneys understand that as well. The big ticket items, this is the final point, the big ticket items, the headline makers, the $25 million verdicts, if you look at them, they're almost all coming from a small handful of lawyers with profoundly injured baby cases, men and women who are, for the most part, highly skilled, have carefully screened the cases, and where the cutting edge is the huge injury. Some of the cases, though, get through by luck or stupidity, but I wonder how many there are there. But we as a legal profession have to do much better, no question, in deterring frivolous claims. There's no debate about that.
So let me just pin this down. So you're saying that there is a substantial number of people who are injured that don't receive compensation because it never gets, the cases don't get into the tort system because of the mechanics of the system, right? It's expensive.
It's a private sector dispute resolution system that has huge transactional costs.
Yeah.
That's, in plain English, that's the situation. Now, if you want to make a social or political policy judgment that all those who are injured should be compensated, then you need to start talking about a no-fault system, because people with negligible injuries, relatively speaking, need not apply. In fact, if you wanted a reform that would cut out a lot of frivolous claims, and I hate to tell this to the AMA, they're not my best friends, but I will say it here tonight out of an abundance of candor. If you wanted to have if you wanted to change the system and get rid of a lot of these costs and get rid of a lot of these claims, what you do is you would put in a deductible amount. You'd say claims that aren't worth at least $100,000 don't recover. We've had thresholds, so-called, we've had legal thresholds with automobile no fault in certain jurisdictions. And then you would get rid of maybe 90% of the cases. So, Dan, you're welcome.
Donald.
Donald.
But they'd be good friends, new best friends.
Yeah.
You got a guy named right.
Ed, you've been taking a deep breath.
I think there's a piece of that needs to be underscored. The fact is, the tort system from both sides, plaintiff and defendant, is enormously, enormously expensive. And that has a couple of effects. One of those is that people who, as David said, are not seriously injured never get into it. And the reason they don't is because most of the plaintiff's lawyers in my state won't take a case unless there is 6 figures worth of potential damages. Now, if you think about the impact that that has on the population, and if you also think about the fact that what you recover typically in a tort suit, the smaller part of it is additional medical expenses. The larger part is lost income. What that means is that the people with larger incomes are more likely to be represented within this process, and the people with lower incomes are not. And in fact, the data bear that out. Comparison of Medicare and Medicaid patients particularly, age differentials, there's an enormous unfairness. Now back up just for a second and ask, how come it's so expensive? And the answer is that it's fault-based. Because if we think about what a tort trial looks like, both sides need to hire experts. Both sides need to do the kind of investigation that's an enormously expensive investigation to determine not only causation, but did it happen, why did it happen, what were the causes of it, should it have happened, what was going on at the time. All of those things cost a great deal of money. Let me give you one datum. I don't know if this is still valid. It goes back at least 10 years. I haven't seen a more recent number. If we think about the tort system as a social compensation vehicle, it's absolutely abysmal. The number that I want to give you is that of all of the money that's paid into medical malpractice insurance companies in the form of premiums, out of every dollar paid in, 28 cents is used to pay injured people. The other 72 cents are used to pay the system, the insurance industry and the defense industry and the plaintiff's lawyers and everything else. That is almost exactly upside down from a no-fault workers' comp system, which runs on about a 72% payoff or 75% payoff. The difference between them lies in fault and lies in the fact that, again, you can't recover unless you can prove that somebody was operating below the standard of care. I think that piece of it really bears some scrutiny.
Mm-hmm. Don?
Yeah, just go over a couple of points that David had said earlier, that he would rather listen to the Institute of Medicine than the AMA. And I would just point out that the theme of To Err is Human, the Institute of Medicine report, was that it was a systems problem. And that's what we need to focus on. That was the main theme to walk away with in that very important report. The other thing is we have to come up with a way, and it's nice to have someone like David who's been very successful and who can now share the wisdom of how to improve the system, and we appreciate that. In fact, when we formed the National Patient Safety Foundation, we invited a trial lawyer, a very prominent trial lawyer, to be on the first board, and that was very helpful, and we benefited from that. If David could work with the Bar Association and the Association of Trial Lawyers of America, where there really was a meaningful way to do some accountability for attorneys who don't do their homework and file suits. I think the point you made about, well, no one wants to take a case if it doesn't have merit. People do take cases that don't have merit. Why is that? Because of the randomness that Ed has pointed out, that it's not related to negligence. It may be related to a significant injury. And if someone has a significant injury that has nothing to do with what the doctor did or the hospital did, they're saying, wow, somebody just got a $25 million judgment. I can get 33 1/3 to 50% of that. It's an easy lottery ticket buy, because I'm going to buy it, I'm going to refer it on to another firm, and it would be interesting to look into the referral fees and see how much is paid back. And we know that under legal ethics, you can't just refer a case and get a kickback or a payback. You have to get paid for the work. We could look at all of that and see if those incentives are properly being done. But this system just isn't working. What about the patient who really is injured through negligence, but who doesn't have a big money claim? No one takes that case. Why isn't that patient taken care of? We ought to have a system that takes care of patients quickly, promptly, and most importantly, and I've been all over the nation listening to patients in the audience at patient safety meetings, and what they all do, what they all say, if you had to summarize, they go to the microphone, they say, I want to know what happened to my baby. I want to know why my baby had this problem. Tell me. That's the first thing they want to know. And the second thing they want to know is, what are you going to do to prevent it from happening to someone else? Now, 50% of them will say, we'd also like to have somebody tell us they're sorry. But the first two things, and we think that's very important too, to say you're sorry. But they want to know the first two things. And right now, there's this wall of silence. Lawyers, defense, plaintiff attorney, everybody gets in, discovery, don't talk to anybody. We don't advance safety that way. We have to have a mechanism where you can have free communication. We do. Harvard is well known for this. Everywhere we go, where there are giant medical centers, we have Death and Complications Conference. We have grand rounds. We try to learn from each other. We find that that is now being throttled a little bit. People are afraid to say things. Somebody may be a runner, and suddenly, next thing you know, you're sued. We got to get into an atmosphere where we can freely communicate and learn from each other. The patients deserve that.
You know, Don, I asked the dean of a major teaching institution in this country, I said, would you set aside just 10 hours during the year, at the end of the day, an hour, 10 sessions at the end of the day, where residents could come to a conference that had to do with communications with patients, making the patient a learned and valued partner in his or her own decision-making, which a lot of people think should be the 11th commandment in the practice of medicine, and create a line of communication of the sort you're talking about. I served for a year or two until through what I'll call disuse atrophy, I gave it up in a teaching hospital in Philadelphia to do just that. One or two guys would show up at the end of the day because it was not a mandatory part of the curriculum. I think there should be, and I think it should enjoy the formal support of the AMA, a mandatory piece of the curriculum. It needs to be a small piece about these recurring issues that you read about in letters to the editor in the New England Journal of Medicine, communicating with patients, better communication, explaining bad results, not to be afraid to explain bad results, not to be afraid to say, I'm sorry. Not ever to be tempted to cook the books, of course, in terms of charting, to residents who write letters. You and I have read these letters in the medical journals. I'm working 14 hours a day. I can't keep up. I'm spending 3 hours every week on non-clinical tasks, things that have to do with the quality of life for the physician in the hospital and for the residents. I couldn't more agree with your remarks.
A few minutes before 7:30, I'm going to come back to our panelists and ask them each succinctly to suggest a better system. But now we're going to turn to the audience, to a conversation with the audience, and would ask anyone who wants to ask a question to use one of the there are microphones on the floor up in the balcony alcoves. There are two conditions for hearing your comments. One is that they be succinct and that they end with a question mark.
Dr. Palmisano, I heard you at the STS, and I wanted to thank you again for all your efforts you've done. Dr. Schrager, or Mr. Schrager, I'm glad you're here as well, taking the heat. We've been enrolled in a course this week about skills for New World Health. We have heard about the errors in medicine, and that there are approximately 3 to 8% of errors that are adverse and can be avoided, and they're misuse, overuse, and underuse. It seems to me, though, that the system is equally broken in tort reform. And considering the amount of effort that's being spent to correct the medical system, what sort of effort is being thrown at the tort reform system to correct these errors? Because if we have a 0.3% overall adverse event rate, you're hearing the numbers, it's about exactly the opposite.
Right.
Tort reform.
Right. A lot is happening, though I think a lot more should happen. What's been happening is that the medical community has finally, and many of us wondered when, gotten much more involved politically, have become politically more responsible citizens in terms of supporting candidates who are interested in tort reform, when, if the truth were to be told, for many, many years, they were giving out PR statements and nothing more was happening. We obviously have a more activist situation at the AMA than we had in previous years. What's been the effect? Claims have gone down. The numbers of cases have gone down. And in Pennsylvania, I think the last numbers I saw were significant. Why? Medical malpractice claims have become suspect. There is a perception in the public that these cases should be challenged. My partner, who I regard to be one of the, beyond any chauvinistic interest because he's my partner, I regard to be one of the finest trial lawyers I've ever known in my professional career, has tried, and his experience is replicated by other outstanding trial lawyers with what I will ask you to assume for purposes of discussion are clear cases, straightforward cases, and the juries are being voir dired, that is interviewed before they're put in the box, and say they can be fair, and say they're not going to be influenced by the editorials they've read in the newspaper, and they are bringing in verdicts for the defendant. The loss rate used to be, if you had a good case, used to be 50% of the cases you would go in and know you would lose. The figure is, I would say now, closer to 3/4. We have certificates of merit. You have to get a doctor to sign on the dotted line within 30 or 60 days, whatever it is, after you file a complaint. There are hurdles that have now been introduced in the system. So it may well be that as we sit here this evening, substantial reform is occurring.
Question up there.
Yes, my name is Sylvia Clute, and I'm a student in the mid-career program at KSG. Before coming here, I was a trial attorney for 28 years, which included plaintiffs' work in malpractice cases. And my question goes to the systems reform. But I think that the last example of systems reform is not what I'm talking about. About halfway through my career, I decided that this win-lose paradigm was very destructive. For one thing, we attorneys know that lying is rampant in the system because the stakes are so high. I mean, it's everything or nothing. When someone, for example, has a baby that's seriously injured, you need money to care for the baby, but there's also a lot of spiritual healing that has to take place. And when clients would come to me and there's a break in a relationship, nothing I did as a trial attorney addressed that. Is anyone looking at how we can change the system so radically that we can look at healing and restoration and, really bringing an opportunity for the doctor to say, yes, I am sorry, and how can I be a part of the solution? It would be ridiculous now for doctors to do that under the present system because it's an admission against interest. We would use it against them.
That's a magnificent segue to what the dean does in terms of mediation, alternative dispute resolution, and the like.
Ed?
The answer is yes. There are some very interesting experiments going on that are premised on exactly the insight that you've just shared, which is that there is a therapeutic and anti-therapeutic possibility in all of these encounters, and the present system is decidedly anti-therapeutic on both sides. We have begun to learn that the power of apology has not been exaggerated. There really is significant power to it. There's also a medically therapeutic benefit in restoring conversation between physician and patient. There's an experiment going on by a large insurance company that hasn't made it public, so I can't mention their name, in which what they're seeing in the aftermath of an injury, they try to restore communication between patient and plaintiff. They provide compensation for whatever the actual losses are, not the kinds of things we see in jury awards. And they see that relationship between doctor and patient continue. In addition to assist that, many states, there's now, I think, 8, and legislation pending in about 5 more, that have enacted something they call apology bills, or also known as the I'm sorry law. The problem is, or the problem has been, that if a physician in the aftermath of an injury where there's the possibility of a claim would like to take accountability, not responsibility or liability, but accountability, and talk to the patient, the fear has been that anything they say to the patient will be used and evidenced against them at the inevitable malpractice trial. These apology laws are designed to foster precisely the kind of alternatives that you've described by saying anything said in that conversation is privileged and inadmissible. Now, there's a lot more to be done, but the insight you shared with us, I think, is the opening wedge of a very useful future.
Mm-hmm. So you're suggesting, just to underline something, which perhaps we all know, but that there is some disproportion often between the the degree of injury and the award. There's another problem in the compensation system?
I'm not sure exactly what you mean by between the injury and the award.
Well, you said in jury cases, implying that the jury sometimes makes decisions that are out of keeping with what other people might.
Well, there's a couple of problems built into the system. I'll just mention a couple because there's rather a lot. One of them is in most states, the jury only gets to compensate a plaintiff once. So that if you're looking at somebody who may need help over the future, or may not need help over the future, all of that has to be packed into an award they get today. It's not possible typically to say, we'll pay as we go. You may need care, you may not need care. This baby may need rehab, may not need rehab. Instead of coming up with some number today that is the phobia kind of case, let's have a schedule of benefits that takes care of you as you go. The other difficulty, just to connect it to the questioner's comment, is that there are some forces running counter to the notion of moving towards these mediated sort of solutions. As somebody once said, plaintiff's lawyers can't live on a third of an apology. And so to the extent that the liability system uses money as a surrogate for all sorts of other things, it's going to be very hard to create a parallel alternative. It's a challenge that has a lot of difficult wrinkles in it.
Well, just on one little subset of that, there are alternative systems to trying to figure out how much money is needed in the future, and you get people, as the eloquent lady said up there, that people sometimes, I think you used the word lie, and the AMA, by the way, we're opposed to anybody, defense or plaintiff expert lying, and we have some strong policy. We believe testifying is the practice of medicine. You should be held accountable if you don't give proper science and if you lie. But for instance, in Louisiana with the Patients' Compensation Fund, when someone wins an award, for the medical portion, future medicals, they don't get a certain amount of money. They get a ticket to the Patients' Compensation Fund. And it could be that they'll get $50,000. It could be they'll get $1 million. They get the money when the treatment's needed, as incurred. So if it turns out they need $2 million in the future for rehabilitation, for operations, they get that. But they get it when the treatment is rendered. So you don't get into all the speculative ideas where they need this, and then the patient dies. But that money's already been given, even though it's going to be for future medical treatments. So that's another way to look at it. And you could have, as you say, a schedule of benefits, because there are very few countries in the world that use our system. I had the privilege to be in China recently to give some speeches last week. And one of the things I said, there are many wonderful things here in our medical system, but we have some problems, and one of which I would not recommend that they capture is our medical legal system. It would be better to look at multiple other options because it's destroying the practice of medicine, in our opinion.
Yes, sir.
My name is Dr. William Flynn. I'm a surgeon practicing in this area. I'm on the faculty of Tufts and Harvard, and I have a very busy practice. I've also been in court a number of times as an expert, at least 40 times. I tend to review cases a lot, both for plaintiff and defense, and so I kind of know what I've had a lot of experience with this, and I feel I'd like to make a couple of comments and boil it down to a succinct question. First of all, I don't see that my profession needs the incentive from any system to pursue excellence. Dr. Palmisano briefly mentioned the intensity with which surgeons police themselves. You wouldn't believe how active it is. My brother is an airline pilot, and he and I love to sit down and talk about how we are both in professions that police themselves, throw out the people that aren't good at it. One of my hospitals 2 days ago threw a surgeon out the door to the front page of the Herald before he could cause any trouble, and I'm proud of that. Our system did that before anybody in the state got involved in it. So we don't need this system to tell us how to police ourselves. Secondly, there's no question that until this system is changed in some way, there are some cases where there's a deviation from the standard of care, there are serious damages, and there is causation between them where something should be paid. None of us question that should happen. But I've seen a number of cases that I've been involved with and read of some where these spectacular settlements that are often based on a lot of emotion rather than the facts. We've heard that discussions of this should involve around measurable data rather than any anecdotal or trivialized political things. Well, I would turn that around and say that settlements should really involve actual damages that are incurred. No one has really mentioned here a push to have caps on non-economic damages, which is, I think, what most of the medical societies around the country and the AMA are pushing for. None of us want to get rid of awards for serious errors to compensate the patients for their losses. But caps on pain and suffering of $500,000 or $250,000 are not caps on damages that patients deserve. They're caps on emotional awards. And I have seen many at times, and I'm sure those in the panel have seen, a few awards that are so out of scale, they throw everything off the scale, and everybody's premiums go up by $5,000 because of these emotional awards. Yes, yes. What about yes, the question is, what about the issue of caps on pain and suffering? That's my succinct question.
Okay. Yes, Tom.
Well, if I might just start off, we certainly agree with that. In other words, that's something that's subjective, it cannot be quantified, and there's no way to predict what it'll be. And it affects settlements also, because if there's a huge award, in some jurisdictions, 60% of the award is the non-economic or, quote, pain and suffering type damages. So we believe there's a proven model. All of these other ideas in medicine, it's a hypothesis, and use a scientific method. We have a proven method in California, the micro law, $250 fixed cap per incident, not per doctor, per claimant. Sometimes they say caps don't work. Well, Missouri is an example where caps don't work. It's a cap per doctor per claimant. You could have 5, 6, 7 caps in a case. It's the California model, $250 non-economic cap, plus the other items, the limits on the contingency fees, periodic payments, the joint and several liability, statute of limitations, all of those play together. So that would be a very important role. What would be the final answer? I mean, what results? What's the consequence of that? The consequence is states that have good laws like that, Louisiana, Indiana, New Mexico, Colorado, and Wisconsin, the 6 states that have those laws, they're the ones that don't have access to care problems. Physicians are remaining in those states, and they're moving out of the 19 states in crisis into those states. So people benefit from that. Also, the American population agrees with that. 72% in the Gallup poll, January 2003, they're in favor of caps on non-economic damages and limits on contingency fees. The United States Congress, the House of Representatives, they passed H.R. 5, which is exactly the micro bill. The Senate, a minority of senators blocked it from going to full debate and discussion. President's in favor, Secretary Thompson, Dr. Frisk. So essentially, we know that the majority of Americans want this to happen, and there's a small group preventing this from happening. But it will happen. And that's going to be the emergency fix.
Yeah. Caps are an important issue. David?
Yeah, sure. Well, as an aside, I would like to say to the questioner that there is a consent requirement by physicians before a case can be settled. The physician has the right of veto, and you're making a good argument that that right ought to be more generously exercised. As to caps, I am unaware of the data, and I suggest there are no data whatsoever, which correlate the movement of physicians out of a particular jurisdiction with whether or not it has caps. But as to the caps issue proper, of course you can have caps. You need to make a policy decision. We need to make a judgment as a civilized and humane society that if somebody has lost a leg, if someone is paralyzed from the waist down, it's $250,000 or $500,000, and that is and that's what you get forevermore for compromise of your lifestyle of a profound sort. I am also unaware of the data which suggests that there are any number of verdicts not reduced on appeal which show that there are these mega million-dollar verdicts. We've not talked this evening about the fact that the system itself, to borrow a page from the last questioner's comment, in which the judicial system, this doesn't appear in the newspaper after the verdict, cuts these verdicts down, reduces the verdicts substantially. We hear about $1 billion in collective awards. The actual amount paid out, millions of dollars in collective awards. So there's a lot of romance and legend on this subject. What we need would be for Michelle and her colleagues to come to the rescue and give us the serious data that will correlate what the impact has been of general damage verdicts in various jurisdictions, of caps and awards on various jurisdictions, how the medical community is fleeing those jurisdictions. Let's go wherever the facts take us. But in doing that, we should follow the academic discipline, and Michelle, whatever you decide, we can go on from there.
Well, Michelle, the floor is yours.
Thanks. Well, I think to some extent the jury's still out on this empirical question, although we're beginning to get a couple of good papers now that help us really understand the effects of caps on costs. And I think the data are converging around conclusions that they obviously have an effect on losses, because the literal effect is to limit payouts. They have a pronounced effect on premiums, but not in the short term. Over the medium to long term, they're not going to reduce premiums. They're going to perhaps stabilize or constrain the growth to some extent. And with respect to physician supply, there's some evidence of a correlation between the growth of physician supply and the presence of certain tort reforms in a state, although it's always impossible to control for all the other factors that affect where physicians to set up practice. So, I think there's some reasonable evidence that caps work for the limited purposes for which they are adopted. But I would suggest that these kinds of decisions are about more than how can we make malpractice insurers cheaper for physicians. This is fundamentally a social judgment about who we want to compensate for medical injury and how we want to compensate them. And we ought to be deliberating about this as a polity and hopefully outside the heat of a malpractice crisis. And I'd suggest that despite the fact that caps may constrain premiums and have all these other beneficial effects, we can maybe be a little bit more sophisticated. Once we make a social judgment that we do want to limit damages, can't we do a little better than the Procrustean measure of simply chopping off the legs of this damage award at $250,000, which was a level chosen by California, a quarter century ago. The real value of that amount today is about $75,000. So there's nothing magic about that number except that we have data showing that it has a salutary effect on premiums. But if we take the bigger social question of what are we trying to achieve with competition and what's reasonable, I'd suggest that the next generation of tort reforms ought to be looking at something more along the lines of what David suggests, a schedule of damages that has some components of both horizontal and vertical equity. Let's pay people who have similar injuries the same way, and let's pay people who have more severe injuries more, and that's where caps tend to lose out. So that's what my colleagues and I are working on, and I hope that it will receive some policy attention, although I think in the context of the malpractice crisis, it's understandable why we tend to focus on solutions that we've tried before and that seem to work for addressing that problem.
Seems to me I once had an insurance policy that paid $50 for a thumb, $150 for a hand, so you're suggesting maybe we up here.
My name is Rachel Zimmett. I don't mean to set the conversation back. I feel like we've covered a partial answer to what I wanted to talk about. My father, until last year, was an orthopedic surgeon practicing in Pennsylvania. He left. and moved to another state where the medical malpractice premiums were lower so that he could actually make a living. It was not an immediate forced decision. One of the reasons he decided to move was that he looked at the number of malpractice insurance providers in the state of Pennsylvania and saw that it had fallen in half over the previous few years. And I was wondering, we talked a lot about tort reform, we've talked a lot about the compensation issue, and in terms of doctor supply and availability, has anyone looked at reforming the actual malpractice insurance structure so that we can maintain these insurance companies through reinsurance so that doctors, no matter what state they practice in, will continue to be insured?
Yeah. Ed?
I think that's a really good point. Despite the fact that we've had 2 rounds of tort reforms in the 70s and the 80s, here we are again. There is an insurance pricing cycle that seems to be utterly unconnected with anything that has to do with anything we've talked about. People have looked at it to see whether it's connected with increases and decreases in tort judgments. It's not. Although over time, tort judgments rise because there's medical inflation, and over time, insurance premiums rise. But the cyclic nature of it is utterly unconnected with anything. There is a real argument to be had here. On one side, and this I hope will get directly to your question, on one side, the explanation for the current crisis that we find ourselves in, the effects of which are real, as your father's case, I think, demonstrates. That crisis comes not from anything going on in the tort system as much as it does in the marketing behavior of insurance companies, which during times of low premiums are keeping premiums down to increase market share. They get a lot of market share, and then something happens, it begins turning up again. They've underpriced for a very, very long time. In fact, in most states, doctors haven't been paying enough until a couple of years ago, if you just look at a secular trend over a long period of time. And so they play catch up all at once. And then it begins to crash. What happens is when payouts go high, insurers leave the state, which exacerbates the marketing crisis. During the 1986 tort reforms, some states looked at stabilizing insurance markets as an objective independent of all of these other things. Caps don't stabilize insurance markets. They limit them, just as they limit everything else. There are a variety of ways in which that can be done, but the fact is that the tradition in the United States is to not have a lot of regulation of insurance prices. In most states, you can come and go. It's called a file and use kind of system. You don't need any approval. And so what we're seeing is market forces, and I think we need to remember that because some of the emergency nature of where we are today is a result of the economics of insurance, probably as much as, at least as much as anything else.
David, you said many comments.
Yeah, Ed, I was wondering whether you would comment as well on another facet of this in terms of rating classifications, where high-risk specialists, such as perhaps the questioner's father, would be paying a premium which, given whatever his income level would be, bears no proportionality to the very much smaller premium that a general practitioner would make, even as the high-risk specialists take off the shoulders of their general practitioner or frontline medical care provider colleagues a lot of the risk.
One of the advantages of the enterprise liability model, which Michelle mentioned earlier, and that is where an organization like a hospital or a health plan covers the insurance costs rather than the individual physicians, is that as much as it may not feel like this to anybody who's been involved in one of these cases, a malpractice claim is an extraordinary event. Mm-hmm. It's really rare. It's in the life of an individual physician. I would almost say it comes out of the blue. And it's very, very difficult for an insurance company to do experience rating on the basis of extremely rare events. And so to say that we ought to have insurance premiums that actually follow the real risk level of this doctor versus that doctor or this specialty versus that specialty is extraordinarily difficult. If, on the other hand, we have enterprise liability, and if the enterprise that's bearing the liability is insured, or even if it's self-insured, it can do its underwriting on a much more stable basis because it has a larger portfolio of numbers. Insurance works on the basis of the law of large numbers. And so a real advantage, one of the things behind the argument behind enterprise liability is that it will permit accurate insurance underwriting, which may therefore result in more stable insurance prices.
Donald?
Just briefly, enterprise liability, all that does is just have another deep pocket to pay the money. It doesn't deal with the problems with the system. It doesn't deal with the jury that gives too much money that you say will be turned down on appeal. The very fact that you would admit that means that something's wrong with this system. Maybe Philip Howard is right. We should have medical judges who are trained only in that. They bring in their own experts. But this system is really, really broken. And that, I'll save the rest for the, because I'm going to have the question. I'll save this for the sum up. Yeah.
One more quick question, and then I want to hear from each of them in 2 sentences. What's the better system?
Hi, my name is Shira Pinnis. I'm a junior here at the college. I was wondering how the antitrust exceptions for liability, medical liability insurers have affected the rates that insurance companies charge for medical malpractice coverage.
I don't know.
Do you know, Mel?
Take that.
Michelle?
There was this hypothesis on Capitol Hill last spring that the reason we were seeing rising premiums was simply that we had fewer insurers. And so the remaining insurers in the market were able to exercise their market power and jack up rates now that they had no competition. I don't think there is any evidence for that hypothesis, nor actually do I necessarily agree with Ed's conclusion that prices don't bear any relationship to the financial experience of these companies in terms of their losses. I think the premiums that these companies are charging do reflect both the consequences of some poor business decisions 10, 15 years ago, but also their present experience, which is that their losses are increasing rapidly. So I think there are real dynamics underlying the prices being charged. I don't think it's oligopolistic behavior by a limited number of firms.
Okay, Ed, what's the answer?
The answer?
Yes.
I don't have the answer. I would support at least experiments in no-fault systems, largely for the reasons that I've already mentioned, and that is it would deal with 2 problems as 2 separate problems. One is social obligations to compensate the unfortunate victims of accidents and accidental injuries on the one hand, and when supported by competence-based regulation, deal with the question of medical capability and quality improvement on the other. They are 2 separate things in my mind.
Michelle?
I also would support a system of administrative compensation, sometimes called no fault. I think we should jettison the idea of negligence altogether. I think even if it has some deterrent effect, we pay too dearly for that effect. And there are systems that can do a better job of what I think is the most important function of this system, which is to compensate those who are injured, and that can also do a better job of encouraging providers in their, what I think are fairly nascent efforts to deal with the patient safety problem, but ones that ought to be nurtured.
Mm-hmm. Donald?
Well, we have basically a patient here who's bleeding, GI bleeding, and the first thing we got to do is stop the bleeding. If we can't stop it medically, we have to operate on the patient, and that's why we believe the California law will stabilize the patient. And then we need to look for what's causing the bleeding long term, whether it's a Zollinger-Ellison syndrome, whatever it is, and we believe that one of these methods here, we believe that this current negligence system does not serve us well. Right now, the insurance companies are paying out more than they're taking in, and I would encourage everybody, because the time is limited, but go to the AMA website and read Medical Liability Reform Now, 29 pages, goes into much more detail about these issues. But we need to go to an alternative system at some point, and that's why AMA has agreed to study the Philip Howard type model medical courts, look at no fault. We're looking at all those, so we'd love to collaborate with you on those issues.
Good. David?
Well, we're going to have to decide first what we're going to do with this huge volume, the majority of cases we learn that do not participate in the system, people who have small hurts, small harms, but who nevertheless have been victims of negligent treatment in certain instances. We also should have more programs of this sort where the professions meet together and learn from each other, because the lawyers can do better. I believe organized medicine, frankly, can do better. And one other thing, I think we should consider the use more generously of alternative dispute resolution devices, which have been very effective. We haven't talked much about that this evening, but I think it works. I see one of our questioners was anxious to pitch in on that, and so I agree with you. I think we could do a lot. I think the legal system could do a lot, but it needs the cooperation of physicians. There are mediation panels. There are arbitration panels. Arbitration has a very good name and a good track record, and I think could be used much more liberally before we trash the system.
Thank you to the audience for interesting questions and attentiveness, and to our panel, because we all learned something.